Some widely used medications can subtly increase the risk of heart attack, often without people realizing the threat. This review will explore 6 common drugs that may be endangering heart health without you even knowing it. Understanding these hidden dangers is crucial for making informed decisions about your well-being and health. Hormonal contraceptives play a vital role in providing women with effective means of family planning and reproductive freedom. However, their use is associated with varying degrees of cardiovascular risk, and understanding these risks is crucial for making informed decisions about contraception options. Combined hormonal contraceptives, CHCs, which contain both estrogen and progestin, come in various forms, such as pills, patches, and vaginal rings. Studies indicate that CHCs can elevate the risk of arterial thrombotic events, including myocardial infarction, heart attack, and ischemic stroke. An extensive study involving over 2 million Danish women aged 15 to 49 found that those taking combined estrogen and progestin pills had a 2-fold increased risk of these events. Specifically, this translates to 1 additional stroke per 4,760 women and 1 additional heart attack per 10,000 women per year. Notably, non-oral CHCs exhibit even higher risks. For instance, vaginal rings are associated with a 3.8-fold increase in the risk of heart attack. The primary mechanism is believed to involve estrogen's influence on coagulation pathways, leading to a prothrombotic state. Estrogen can enhance the synthesis of clotting factors, thereby increasing the likelihood of blood clot formation. This effect is particularly relevant for women with additional risk factors, such as smoking, hypertension, or hyperlipidemia. Progestin-only contraceptives, available as pills, injections, implants, or intrauterine devices, IUDs, generally present a lower cardiovascular risk profile compared to CHCs. The same Danish study found that progestin-only methods were associated with a slightly elevated risk, but significantly less than their estrogen-containing counterparts. Importantly, progestin-only IUDs did not show an increased risk of heart attack or stroke, making them a safer option for women concerned about cardiovascular complications. But what other medications might be dangerous for the heart? Stay tuned to learn more about these hidden threats. Nonsteroidal anti-inflammatory drugs, NSAIDs, have gained widespread use as remedies for pain relief, inflammation reduction, and fever management. Over-the-counter options like ibuprofen and naproxen are easily accessible. However, despite their effectiveness, scientific research has revealed a link between NSAID consumption and an increased likelihood of cardiovascular complications, such as myocardial infarction and stroke. NSAIDs work by inhibiting the activity of cyclooxygenase, COX enzymes, specifically COX-1 and COX-2. These enzymes play key roles in the synthesis of prostaglandins, lipid compounds involved in inflammation, and various physiological functions. COX inhibition can disrupt the delicate balance between vasoconstriction and vasodilation, as well as platelet aggregation, thereby elevating the risk of thrombus formation. This imbalance is particularly dangerous for individuals with pre-existing cardiovascular conditions. Numerous studies corroborate the cardiovascular risks associated with NSAID use. The U.S. Food and Drug Administration, FDA, specifically notes that the risk of heart attack or stroke can increase as early as the first weeks of NSAID use, and this risk tends to rise with longer duration and higher doses. It's important to emphasize that this warning applies to both over-the-counter and prescription NSAIDs. A comprehensive review published in the European Cardiology Review thoroughly analyzed the cardiovascular consequences of using both traditional NSAIDs and selective COX-2 inhibitors, COXIBs. The review's authors emphasized that the cardiovascular side effects induced by NSAIDs have long been underestimated, leading to increased awareness of the potential risks. It is worth noting that not all NSAIDs carry the same level of cardiovascular risk. For example, diclofenac is associated with a higher likelihood of major vascular events, including myocardial infarction, compared to other NSAIDs. At the same time, naproxen appears to have a more favorable cardiovascular profile among the drugs in this group. Considering the potential cardiovascular risks, the use of NSAIDs should be approached with caution. Before starting treatment with NSAIDs, the patient's cardiovascular history and risk factors should be carefully evaluated. It is recommended to prescribe the minimum effective dose for the shortest period of time necessary to relieve symptoms. It is important to regularly monitor blood pressure and carefully monitor for signs of heart-related side effects, especially in patients taking NSAIDs for a long time. People with high cardiovascular risk should consider alternative pain management methods that carry less risk to heart and vascular health. Thiazolidinediones, a class of anti-diabetic drugs, particularly rosiglitazone, were developed to optimize glycemic control in patients with type 2 diabetes mellitus by increasing the body's sensitivity to insulin. However, concerns about the cardiovascular safety of these medications have significantly impacted their use in clinical practice and shaped their regulatory status. Rosiglitazone functions as an agonist of peroxisome proliferator activated receptor gamma, PPRGO, triggering a chain of events that affect the transcription of genes that play a key role in glucose and lipid metabolism. This process leads to increased insulin sensitivity in peripheral tissues. Despite the effectiveness of this mechanism in lowering blood glucose levels, it also affects fluid balance in the body and lipid profiles, which can lead to undesirable cardiovascular consequences. Rosiglitazone's cardiovascular safety issues have been the subject of numerous studies and discussions. In particular, a meta-analysis published in the prestigious New England Journal of Medicine in 2007 revealed a 43% increased risk of myocardial infarction among patients taking rosiglitazone. In addition, a number of studies have consistently indicated a link between rosiglitazone and an increased risk of developing heart failure. A comprehensive meta-analysis concluded that, despite the lack of a significant increase in myocardial infarction or cardiovascular mortality, the risk of heart failure was noticeably increased. At the same time, the results of observational studies regarding the association between rosiglitazone and stroke or all-cause mortality have been mixed. Some analyses indicate an increased risk, while others do not reveal a statistically significant increase. The controversy surrounding rosiglitazone underscores the critical importance of careful post-marketing surveillance and comprehensive assessment of drug safety profiles. Physicians should carefully weigh the benefits of glycemic control and the potential cardiovascular risks when considering prescribing thiazolidinediones for the treatment of diabetes. Currently, alternative medications with more favorable safety profiles are often preferred, especially for patients with pre-existing cardiovascular disease or risk factors. In modern psychiatric practice, antidepressants, in particular tricyclic antidepressants, TCAs, and selective serotonin reuptake inhibitors, SSRIs, are widely used to combat depressive conditions. Despite the proven effectiveness of both classes of drugs, it is necessary to consider their potential impact on the cardiovascular system. Tricyclic antidepressants, such as amitriptyline and nortriptyline, exert their effects by blocking the reuptake of neurotransmitters, such as norepinephrine and serotonin, which helps to improve mood. However, their pharmacological properties can have a negative impact on heart function. TCAs can cause a sharp drop in blood pressure when transitioning to an upright position, leading to dizziness and an increased risk of falls. This effect is due to their antagonistic effect on alpha-adrenergic receptors. In addition, TCAs can slow cardiac conduction, which manifests as an increase in PR, QRS, and QT intervals on the electrocardiogram, ECG. Such changes can predispose patients to the development of arrhythmias, including ventricular tachycardia and fibrillation. The anticholinergic effect of TCAs often leads to an increase in heart rate, which can be especially dangerous. For patients with pre-existing heart disease. In this regard, when prescribing TCAs to patients with cardiovascular disease, it is recommended to exercise increased caution, considering alternative treatments where possible. Selective serotonin reuptake inhibitors, SSRIs, such as fluoxetine and citalopram, selectively block the reuptake of serotonin, leading to improved mood. They are generally considered to have a more favorable cardiovascular safety profile compared to tricyclic antidepressants, TCAs. However, some SSRIs, particularly citalopram and escitalopram, can cause dose-dependent QT interval prolongation, increasing the risk of a rare but dangerous arrhythmia known as torsades de pointe. Because of this risk, the Food and Drug Administration, FDA, recommends limiting the maximum daily dose of citalopram. Although less common than with TCAs, SSRIs can also cause orthostatic hypotension and bradycardia. These effects are usually mild but warrant monitoring, especially in patients with pre-existing cardiovascular conditions. Overall, SSRIs are often considered a preferred choice for treating depression in patients with coexisting cardiovascular disease due to their more favorable side effect profile. Nevertheless, individual risk factors and potential drug interactions should always be considered. Pseudoephedrine, commonly used as a decongestant in various over-the-counter cold and allergy medications, is effective at relieving nasal congestion. Despite its benefits, it can have notable effects on the cardiovascular system, especially in individuals with heart conditions. Pseudoephedrine works by stimulating alpha-adrenergic receptors, which leads to the constriction of blood vessels in the nasal passages. This process reduces swelling and facilitates easier breathing. However, it is important to note that the vasoconstrictive effect is not limited to the nasal area. Pseudoephedrine can cause vasoconstriction throughout the body, potentially affecting cardiovascular function. Specifically, pseudoephedrine use can lead to increases in blood pressure and heart rate due to its systemic vasoconstrictive properties. Studies have shown that in patients with controlled hypertension, pseudoephedrine can cause a moderate increase in systolic blood pressure. Furthermore, there is evidence linking pseudoephedrine use to acute coronary syndromes, such as myocardial infarction. The sympathomimetic effects of the drug can increase myocardial oxygen demand, potentially triggering heart attacks, especially in susceptible individuals. The possibility of arrhythmias, including tachycardia, rapid heartbeat, with pseudoephedrine use cannot be ruled out. These effects are a particular concern for people with pre-existing heart conditions or those taking other medications that affect heart rhythm. Therefore, individuals with cardiovascular diseases such as hypertension or arrhythmias are strongly advised to consult with a healthcare professional before using medications containing pseudoephedrine. Alternative treatments with a more favorable cardiovascular profile may be recommended in some cases. Even healthy individuals should monitor their blood pressure and heart rate while taking pseudoephedrine, especially when using higher doses or with prolonged use. It is important to consider that pseudoephedrine can interact with other medications, such as monoamine oxidase inhibitors, MAOs, and beta blockers, which can exacerbate its cardiovascular effects. Therefore, it is crucial to inform healthcare providers of all medications being taken to avoid adverse interactions.